My name is Dr. Ivor Benjamin. I'm a past president of the American Heart Association. I also serve as the director of the Cardiovascular Center at the Medical College of Wisconsin. I'm really excited to be joined today by Dr. Clyde Yancy, who was the lead author of the paper. Dr. Yancy is the Vice Dean of Diversity and Inclusion at Northwestern University and the Feinberg School of Medicine.
So let's start with one of the most important areas that's so obvious that it really merits our immediate attention. In today's world, transparency is so important, and understanding what is a conflict of interest, and in particular, understanding how conflicts of interest have varied over time. However, there was a time where a conflict of interest meant you received an honorarium from a company for being on a speaker's bureau. Conflict of interest might have meant that you were a paid consultant for a company. Those are straightforward, those are reportable. But what happens when you're employed by a hospital corporation and you're on a performance contract? Is that not a conflict of interest? What happens when you are offering CME and you receive a nudge from a sponsor to be certain to focus on this technology, please? Should you divulge that? These are the kinds of nuanced conflicts that now enter the workspace. And what we believe is important is that through transparency and being driven by a quality initiative that is patient-centric, as you've articulated, we can avoid some of the inevitable entanglements that ultimately compromise our works. We can't allow that to happen. One of the other things to keep in mind is that as we have transitioned from the traditional fee-for-service model, which was appropriate, to a value-based model, we can't allow ourselves to deselect higher risk patients so we can have best possible outcomes. Because you and I both know that when we deselect higher risk patients, it's the old patient, it's the patient with multiple comorbidities, it's the poor patient, it's the patient that's been marginalized, minoritized. We can't allow those things to happen. We have to also recognize that when we work in multidimensional corporations, some of those corporations reap a financial return on tests that we order, on procedures that we order. Why does one group of physicians rely on stress echo and another group of physicians rely on nuclear imaging? We have to be careful that we're not nudged in decisions that we make about patients that are driven by other motives. And as we think about our peers in the ACC, who really came up with this important vernacular of appropriate use criteria, it really helps us guide our decisions about what we do for which patient, when, and why.